We're going to start our next panel called Crafting Tomorrow's Healthcare Policies. Up first, we have Matthew Rudberg. Matthew is a certified physician assistant, has diverse healthcare background, including thoracic oncology and colorectal surgery. Currently with UCB's Market Access Strategy Team, he ensures equitable access to dermatologic therapies, particularly for hidradenitis suppurativa patients. Give it up for Dr. Matthew Rudberg. Also to the stage, we're gonna have Jasmine Espy. Jasmine is not only the founder and CEO of AHSID, but also a bold storyteller, nonprofit leader, and health advocate who is redefining what it means to own one's story and leverage it to create strategic partnerships, generational impact, and systematic change. Give it up for Jasmine. Then we're going to have Allison De Batista. She brings nearly 15 years of public affairs and coalition building experience to Woodbury, specializing in healthcare advocacy. She is a co-founder of Epilepsy Alliance America, serves on its board, and uses her strategic communications expertise to influence healthcare policy at state and federal levels. Give it up for Allison De Batista. And last but certainly not least, we have Dr. Stephanie Goldberg. Dr. Stephanie Goldberg is a board-certified general surgeon specializing in emergency and trauma surgery, including hidradenitis suppurativa. Practicing in Prince George, Virginia, she is affiliated with multiple hospitals and has over 20 years of experience, having earned her medical degree from Virginia Commonwealth University. Give it up for Dr. Stephanie Goldberg.
Thank you, Frank. Thank you. Here we have. Well, welcome, everyone. I'm really excited to be here and to be talking about this session here of crafting tomorrow's healthcare policy. Like Frank said, my name is Matthew Rudberg, and I love being able to connect with the HS community. So I want to thank Jasmine for involving us and inviting us to participate in this panel. And I really look forward to continuing to deepen my relationships in the HS community. As some of you heard from my colleague Nicole Williams yesterday at the reception, at UCB, really people are at the heart of what we do, and I can truly attest to that. I'm relatively new within the organization, but I've seen this tangible patients and people being at the center of everything that we do. In my role at UCB, I build and develop strategies around ensuring equitable access for innovative medicines that we create for dermatologic conditions. But beyond that, we really aim to impact the HS community, impact patients beyond just the medicines that we create. So with that said, it's a true honor really to be here today, and I'm looking forward to our discussion. I'm going to give my fellow panelists just a moment to introduce themselves, and I know that Frank did a phenomenal job, but just in their own words, kind of their experience in the policy space and kind of what they're bringing to our discussion today. So you can, Allison, go ahead. Yeah.
I'm so loud. I don't know if I need a mic. But again, Allison De Batista, thank you for having me today. I am very, very passionate about putting the patient and provider voice into legislation and what that means in state, federal, and even payer relations, right? Because that is something that we need to work on. So I serve as executive director of the Dermacare Access Network, and we say there are 3 Ps. There's the patient, there's the provider, and then there's policy, and we stay in the policy lane and make sure everybody's connected.
My name is Jasmine Espy. So I've been living with HS since I was 13 years old, and although I've had almost every level of care, as an adult, not being under my parents' insurance, my healthcare has been very flaky. So I've been in spaces where I haven't been able to afford healthcare or health insurance. Right now, I don't have health insurance. And it's an interesting space to be. I'm lucky to be in remission, so I don't need it. But if I ever fell out of remission, I can't imagine what would happen, And so For me, doing this advocacy work means not having situations like mine or what other people are experiencing, like having insurance but not being able to get HS surgeries, which I've experienced as well, or being denied seeing a specialist because you have HMO and you don't have PPO. All of that red tape just needs to go away because it's ridiculous. And it creates continuous gaps in care, and we need to be taken care of as patients. And it happens at a systemic level of these disparities. And so I really want to, that's the reason why I'm on the HS Coalition, is because I want to change current generation, but future generations need so much help so that they do not have to deal with those things ever again. So that's why I do this work.
And hi, I'm Stephanie Goldberg. I'm a surgeon, and I specialize exclusively right now in HS surgery, which is really a privilege and an honor. I became interested in HS about 20 years or so when I realized that the information that we're taught in our surgical training was not consistent with what I was seeing in clinical practice, and that the procedures also were not necessarily appropriate. And just jumped into this space and have really enjoyed the relationships that I've built with many of you here. I'm a board member of the HS Coalition. I'm also the president of the board of the HS Coalition, which is very exciting. We are working to change policy alongside each other for the group, and I think this is a gap that's been missing in the HS world for quite some time. For me as a surgeon, I am often the primary entry point for a lot of patients with HS into the healthcare system, and I see the barriers that many of you face, including lack of access to dermatology. And my other hat that I wear is that I'm in physician education. So I also see some of the barriers that exist on the healthcare side of us limiting the number of physicians who are entering the workforce, especially dermatologists. So I'm hoping we can have some significant impact there as well.
Great. So my first question is, and a lot of you touched on this, but as we think about kind of crafting tomorrow's healthcare policies for HS patients, and if we were to look externally into other disease states, other chronic diseases, are there things that we can learn that they've done really well, where they have innovated, and we could bring that into the HS community and really learn from that and allow us to springboard and be more effective? So Allison, I'll start with you.
Okay. Well, I'll start by saying this is a really exciting time for the disease state. And you might look at me like I'm crazy, but there's new and innovative therapies that are coming to market, and that's really promising, right? Because what you've seen with other chronic diseases, say diabetes, epilepsy, it's been around a long time, and there's been treatments for a long time. And so there's a lot of generic therapies that people can get access to. We've learned about patient-centric care where there's self-management tools that we can teach people. So this is like we're on the cusp of being able to do all that, but none of it's going to work unless there's equitable access to innovative therapies. And I think what we really need to focus on right now is when we talk about having access to these medications is making sure the patient-provider relationship is at a whole, right? There's all these third parties that are in a room with the doctor when they're prescribing, and they need to get out. So I can tell I get passionate about it. But so I think it's making sure that decision makers and on every level understand what it is and how we can address it, and that kind of levels the playing field to where people can get access to the treatment that they need.
I think when we experience barriers in the healthcare system, a lot of us don't know why we're experiencing these barriers. And so for me as a patient, I think it's important for other people living with HS to understand what those barriers are so that they're not disempowered, but they realize it's not your fault, it's the system's fault. And there is something you can do about it, whether it's speaking up about your experience or whether it's going to these, legislators and asking them by telling your story why they should change these policies so that you can get the help that you need. And so I think when you remove the blinders off, because I feel like it's almost like a Wizard of Oz situation where it's like there's this big, scary person who's projected, and it's like, oh, they're controlling this system. But when you move the curtain back, it's a small little person just behind there, just like pushing, but it's just ridiculous.
Often a high school kid with
Exactly.
with a hoodie.
Right, exactly. So I think that, empowering patients to understand that could do a lot of great work, in general. So, yeah.
Jasmine, one of the things you mentioned was the why. And I think the why is the most important thing here. And it's interesting, you had asked about other disease states. And when I think about it, and I am by no means making any kind of correlation with this whatsoever, but if we look at HIV care, for example, at least in the state of Virginia, everybody has access to HIV care. You will not be denied, you will get the care. So we think back to the why. How did we even get to this point? To try to use that to understand, well, how can we ensure that patients have access to HS care? Well, if you look at the HIV, it was in the midst of the AIDS crisis in the 80s, and the intent of doing this was try to help the spread of disease, even more so, I hate to admit, than probably trying to affect people's health, so to speak. So we go back to HS, and what's the why? Well, the why is it's not a contagious public health crisis or anything like that, but there's significant patient suffering, impact on quality of life, and we have to get the people who are sitting, as the little Wizard of Oz guy, or whatever you want to call it, but behind the curtain, to understand that they need to reframe the why of what their policy making is.
Yeah, yep. Dr. Goldberg, my next question is for you. As a healthcare professional, how do you think about collaborating more effectively with health systems to advocate for your patients, to prioritize and to push those health systems to prioritize that patient-centered care and equitable access for patients?
If I had an answer to that question, we would solve on the problem. I don't think the issue is actually on the healthcare system level. I think it's actually a bit further back. I think, and I have to be very cautious what I say, but I honestly think it starts on the level of regulation of care. So we have a gazillion people who want to go to medical school right now, and our acceptance rate is incredibly low. And these are very smart, intelligent people. So we are regulating the number of physicians that we put out there into this community. Another layer, dermatology. Sorry, Dr. Dave Louie and Dr. Cotton. It is one of the most competitive specialties out there. These are the creme de la creme, and there are only, 190-something positions a year? Residency position. It's under 100 residency positions a year, and it's regulated, and that's it. And you have all these other people who are smart, who want to go into dermatology, and they don't have that option. So we are stabbing ourselves in the foot as far as availability or access to care. Then on top of that, you have the payer situation, where the reimbursement model that exists for physicians or health systems to get paid, and there's a little bit of a myth that dates back to the 1980s of how physicians used to do and how they were only out for money and blah, blah, blah. But physicians now are highly regulated by their own healthcare systems in terms of their pay and so forth. So the reality is that most of the procedures we do don't reimburse much. In fact, for the procedures that I do in the operating room, I will get the same reimbursement as if I take 2 seconds to drain an abscess in the office, which is kind of crazy if I spend 3 hours working on a patient. So all of these barriers are problematic, and the reality is that healthcare systems don't know how to solve them, and they don't have the bandwidth to figure out how to solve them, because they, frankly, have so many other metrics and things that they have to follow and regulations that they have to follow. So someone needs to take a step back and take a really good hard look at what is important in healthcare how did we end up in this space which frankly doesn't make a lot of sense. And then based on that, really, we need to blast the system and build from the ground up.
Yeah. Jasmine, this kind of forays into that same or similar question, but when you reflect upon your kind of healthcare journey, you just shared a little bit about your, insurance and being on or off, but what do you think are some of the most pressing obstacles you encounter in accessing timely and effective care, and how do you envision, creating these healthcare policies that address these hurdles, but at the same time ensuring improved healthcare outcomes for HS patients?
So, like I was saying before, my journey has been like a spectrum. A lot of the reason why I'm in remission today and I've had such success is because of access to the system, But at the same time, I've also been, tossed to the side by it too, because I didn't have that access anymore, that privilege. Let's call it what it is, it's privilege, And so I think for me, in my journey, I remember when I wanted to get, for an example, when I had severe scarring and drainage in the buttock area, I wanted to get wide excision surgery. I called I think it was a clinic in LA, and I was trying to see if I could, see someone, and I think I had state insurance at that time. And so they didn't take my insurance, but they quoted me a price of, I think, $20,000 to do the surgery. And they said even if I did have insurance, it might only cover $10,000. So I'm like, if I had $20,000 laying around, I wouldn't be talking to you right now. I'd be someplace else. You know what I mean? Things like that can be very disheartening, and I was at a point in my journey where, I was amped up on hope. So I wasn't discouraged. I just reapproached it. And I had access to physicians who could help, redirect me, which again is another privilege. You know what I mean? Everybody doesn't have that. But having, those relationships, and that's why I'm glad that, people like Dr. Goldberg are here, Dr. Hamzavi, Dr. Dave Louie are here, because when you build relationships with physicians, you can pull on them to say, hey, is this correct? Is this, what do I do in this particular situation? Now, they can't give you medical advice if you're not seeing them, but it's definitely a great opportunity to, ask them questions so that you can get guidance, so that you're not just left in the system just floating, and you're just, hopeless, And so I think that creating, an action plan for yourself, where you can lean on different support systems. My therapist talks about having pillars of support. And so it's if you have a physician you can call, you have an advocate you can call, you have an organization you can reach out to, then you have pillars in place that you can kind of are these little things of hope where you're just okay, if this doesn't work, I can go here. If this doesn't work, I can go here. Mm-hmm. And you can just keep working towards what you're looking for, which is healing and some type of management. So I think that's helpful, and I don't know if that's more of I don't want to say esoteric, but more of an action plan for patients, but for the system in general. I just wish a lot of the barriers and things that we had to experience just weren't there. And I think that some of the things that we're doing, lobbying for getting rid of step therapy, so that, patients are not having to fail on a medication in order to get access to another. So it's if Humira is not working, for an example, you're not having to wait a whole year before you can get access to Cosentyx, and then in that process, you develop something else, or you get sicker, or something of that nature happens, which you shouldn't be subjected to. So when we change those different things and take the politics out of it and put the patients there, then we can actually make, actual change. So I hope that answers your question.
Yeah, I think so.
Okay.
Yeah.
And can I add one thing that Jasmine said? So HS surgery is covered by insurance. It is a myth that it's not covered by insurance. There are some people who don't take insurance and want to do direct-to-provider pay, or there are people who may have insurance plans such that they have a high deductible, for example, and they may have to pay the deductible prior to the insurance kicking in. But the codes are all covered. The other space where people may experience difficulty getting their surgery, quote unquote, covered is if a physician decides to code it differently, for example, as a subspecialized surgery that has a higher reimbursement, worth probably what it's truly worth from a physician reimbursement standpoint, but because of that, insurance says, well, this isn't, this doesn't reflect what you're doing, we're not going to pay for it. So keep asking those questions if you ever hear that it's not covered by insurance, because it is.
And can I say something too? My mom used to work for a healthcare agency as she was a instructional designer. And so one of the things that we dealt with, because I remember I couldn't get care for something. I can't remember what it was, but she told me that you can grieve insurance agencies by writing them letters and sending in like pictures of like your condition to get them to cover, different procedures if they keep denying you. Because it's like, okay, so you don't believe that I need this surgery, so let me show you the pictures of what I'm dealing with, because you just think of me as a number. So I'm going to show you my experience so that maybe that'll influence you to give me access to care. So that was one of the tips that she gave me. It's a long process, it's exhausting, but it can be helpful.
Yeah, in your experience, Dr. Goldberg, so, getting on the phone, doing these peer-to-peers, or sending in those letters of medical necessity, or all of these, can you speak to kind of some of those barriers and policies or ways that we could advocate to improve them? I know that I'm sure that it's a headache for you in your practice.
Fortunately, I've worked my way around a lot of those things. But the physician interplay with the insurance company can be very challenging. There's a lot of what we can and what we can't do, and there's not a lot of gray area. So for us to change, all the insurance companies, they basically have algorithms that are written out for how you're expected to practice. And if you deviate, if you prescribe something that's different, whether it's a different drug, they're going to say no, and they're not going to cover it. And then what happens is we have to get on the phone with someone who may not even know anything. They're a physician, or they might be a nurse practitioner or a physician assistant. They may know nothing about this disease whatsoever. And we have to explain to them why this is important. And honestly, it depends who's on the other side of the phone in terms of figuring out whether or not it's going to be successful. Because if it's someone that we can tug at the heartstrings, or is open and willing to collaborate and willing to listen, we can get things approved. And otherwise, it can be very, very resistant. I think to some of the big spaces where we have a lot of work to do, one of them is access to wound care supplies. The other is going to be early access to dermatologists, and trained dermatologists who really are comfortable knowing what they're doing. What I'm finding in healthcare in general, and I say this only because I also oversee a nurse practitioner training program, which is fantastic. But from a American standpoint, or a workforce standpoint, our response to the physician shortage, instead of letting more physicians in, is to expand this population of advanced practice providers who can fill that gap. And many of them are excellent. They've been doing things for many, many years. They're trained on the job very well. But right now you have all these folks who are going to NP school, and frankly, it's a moneymaker. They're coming out with very, very little clinical exposure, and they're being put in these situations where they have to practice medicine without any support, any guidance. And those are often the first people you're going to see when you go to a physician's office. And that's adding another layer, another barrier to be able to get health care, because that's where you might be hearing, we can't help you, or so forth. And you know, it's another space that we really have to influence as we work to expand access to care, because it's not working. And then the other thing is the pre-authorizations and the access to biologics. So when we look at the studies that were done, at 3 months after people have been prescribed their biologic medication, most of them are not on their biologics yet. So think about the frustration of having to wait, knowing that there's something out there that could help you and that you just can't get it. And there's multiple calls to the doctor, and the doctors are calling, or the providers, are calling the insurance companies, and it just ends up in this cycle. And frankly, a lot of times 6 months will go by and everybody has just kind of forgotten about it, and then you have nothing. So those are other spaces, and I think actually I'm going to comment on the HS Foundation. Brent, our executive director, is in the back. They've been really doing great work to help provide, Dr. Dave Louie as well, to provide evidence-based approaches and letters that you can send to your insurance company. They're all on the HS Foundation website, which basically say, this is why this drug is important. Here's all of the research studies that you can look at, and please approve this medication for this patient. But until we change these things at the insurance level, at the public policy level, everything else we're doing is just responsive in nature. It's a Band-Aid.
Yeah, I was going to say, Allison, you, as the policy guru with us here, we've identified a bunch of gaps here. When you put your policy hat on or your advocacy hat on, what are things that we can do in order to fill some of those gaps? What is maybe some of the things that you've been seeing happen? I think somebody mentioned like step therapy override. Where should we be putting our energy to try to advocate and fix some of these things?
Yeah, sure. I think real quick, I'm going to take a step back and just explain to everybody, before this becomes like a payer-hater panel, it's a hate the game, not the player kind of thing here, because what they're doing is completely legal. It's just we need reform. We need to reform the system. So when we talk about access to Medicaid or access to with your commercial plans or insurance, what they're doing is, in order to save their costs, because you need your premiums to be at a manageable rate as well so they can pay claims, they use a tactic called utilization management. And in theory, it's great, right? And there's just no reason, like when we talk about step therapy, that if a generic's on market, you don't start there first. There's no reason. But the problem is the payers have really UM'd this to death, and these tactics have become harmful. So when we talk about step therapy, you're seeing where you have to step through different drugs to get the medication that your doctor prescribed. And that's why I said in the beginning, like, get the third party out the room. Like, the doctor knows what's best. The doctor's not going to be unreasonable, or the clinician, they're not going to be unreasonable what they prescribe. So you're seeing, especially with HS, you're seeing overuse of antibiotics where it's just not appropriate. Antimicrobial resistance is a real thing. We saw that during COVID too. And so, why aren't they listening to guidelines? Why aren't they paying attention to the prior authorization form when the doctor sends it in and says, this is not adequate care for the patient? And so you're talking about reforms that need to be made on both a state and federal level. Federal's a slog. State, you can move some things a lot quicker. I know Michigan has a step therapy bill, which you're probably active in as well. But, when you look at it, you have to say, what's fair? Because we want to go in there and we want to be like, just get rid of it all. Well, that's not realistic. That's not going to happen. But what we can say is, if a patient is stable on a medication, you can't switch them because your contract changed or your formulary negotiations changed. Sorry, that's not fair. They've already tried that medication. They've failed. Stop messing with the patient. And so there should be protections for that patient there. And then also with prior authorizations, what we've seen in Louisiana, prior authorizations are the form your physician has to fill out in order for you to get your medication. And it's a delay tactic, especially when you're talking about biologic. They don't want to spend the money. They don't want to pay for it. The rebate, isn't there. So they want to delay the care. So when you talk about Medicaid and reforms that can be made, we need to look at the prior authorization and say, where's the pain point here? We learned in Mississippi for certain drug classes, they time you out. If you start the PA process and after 30 minutes you haven't completed it, you have to start over again. Clinicians are seeing 20 patients a day. They don't have time for that. So those are really meaningful fixes where you can start. In Louisiana, real quick, with Medicaid, they have a managed Medicaid system. It kind of sounds like an oxymoron. But so what they do is the patients can find 5 different plans. It's like Medicare now. You can pick your plan. So you look at the formulary, like, I take these medications, I'm going to go on this plan. Well, then the next thing you know, a doctor who's prescribing for a disease state has 5 different PAs to fill out for the same medication. So we went in and we said, look, let's standardize this. Let's get one form, make it easy, and that way it leaves some burden, not a whole lot of burden, on the physician office, but there's little tools like that we can work with and help fix it to make it slightly easier.
Are you all familiar with the step therapy laws? Does that resonate with people? No, I see some heads shaking no. Can you just give a quick overview of what does that mean if a state has a step therapy override law?
Right, so there is a bill in Congress called the Safe Step Act, and there's over 300, I think, organizations that support this, and it's for ERISA plans, which are your commercial plans. But basically, it's saying that this is going to be curtailed. If your employer switches plans, it protects you from having to go back and change different medications, right? So that seems like obvious common sense, but it's not. And so here we are. So that's part of step therapy, which works. And then also capping the amount of steps that you would have to take to get to your doctor-prescribed medicine. We believe that anything over 2 is onerous and unfair. So there's states, I think it's 32 states right now who have implemented step therapy override, like you say, making sure that they're accountable. Who's watching it? I don't really know. But hopefully we'll see action during lame duck this year for the federal Safe Step Act to pass and kind of make it like a blanket reform for the states as well.
Great, thank you. So you all 3 are involved in the HS Coalition. Jasmine, I'd like to start with you. Can you just tell us a little bit about the coalition, how it was formed, and what are some of the areas of focus, and then I'll allow the other 2 to comment as well.
Yeah, absolutely. So I'm one of the co-chairs, Dr. Dave Louis is the other. And so we're an organization of physicians, of stakeholders, of patient advocates, and pharmaceutical partners, and we're all coming together to change some of the policy issues and access issues that patients are experiencing. There are other organizations that are banding together, sort of like the Coalition of Skin Diseases, that are fighting these for various dermatological conditions. But when you think about HSC or the HS Coalition, think of it as, specifically focusing in on our community and the issues that we are experiencing. So it's good to think about the whole, but it's also good to zone in on the specific as well. So in my own words, I would say that that's what we do. And we're, working on things like step therapy, prior authorization, and then, recently we've been in talks with the FDA to create a fact sheet for HS because we want them to help to curb some of the misinformation that is being circulated on the internet, and things like that physicians are referring to and passing along to patients. So this is just creating a cycle of misinformation and disempowerment. So if we can have somebody like the FDA, present the correct information, that might help to stop that cycle. So those are some of the things that we're working on, and we have so much more in development.
Great. Want to comment about your involvement? Yeah, go ahead.
I'll just say, I think it's great to have that because the work Jasmine and Brinley and Brent are all doing are like boots on the ground, like work, and they're working with patients and they're helping with the day-to-day. Where I see HS Coalition being super helpful is they're focusing on the policy. So everybody's doing their work, but then they can kind of be that, quarterback. And like, these are the 3 policy priorities we're going to have this year, and we're all going to be united when we talk about this. Now, you all have your own interests. We all have our own interests, and that's what makes things. But the unique perspectives that everybody brings in order to define the policy priorities is what's going to help boil the ocean at the end of the day.
Right.
I was going to say, I think what makes the coalition unique is the presence of the public policy experts and advocates, because the reality is I don't know the first thing about public policy. I don't know how to change it. I don't know how to influence it. I just know that regulations and things exist which have good intent, but a lot of times they make it really hard for us to deliver good quality care. I have a sense of what the barriers as a provider are. Jasmine and Brinley, for example, have a sense of, and the other patient advocates have a sense of what the true issues that are important to the patients are and where the barriers exist from that standpoint. But we really need our public policy partners who understand the system and how to make the change to move it forward.
So how could somebody learn more about the HS Coalition if they were interested?
So we have a website. We also have a LinkedIn page, and is our social media, is that the? Soon come, we have social media. So you can go to hscoalition.org, and you can find out more information about our organization.
Okay, great. Shifting gears just a little bit, I want to take a moment to talk about structural determinants of health. So in recent years, there's been lots of conversation around social determinants of health in healthcare. So that's things like language barriers or socioeconomic status, poverty, food insecurity, those types of things. But there's this growing kind of conversation around structural determinants of health, which more encompass broader like societal factors that influence. So it starts a little bit higher up or maybe upstream per se from social determinants of health. And it's what's shaping the distribution of resources, opportunities, and the living conditions among populations. So these determinants operate beyond individual decisions, really spanning realms such as governmental policies, economic structures, social and public policies, as well as cultural and societal values. So that was kind of a long preamble for this, but how can patients and healthcare professionals really advocate for change at this higher, more upstream structural determinants of health level? Start with you, Allison.
So I think, so community engagement, I think, is, super important as far as, educational materials and meeting the patient where they're at. I think, we get so focused on this is exactly what we need to do, but you can look in any magazine, it's talking about going to the barbershop, going to the church, finding where people are and meeting them at their level, right? I can tell you, too, even the smartest people, and my husband's not in the room, and I will tell you, he is the smartest person I know, but he has zero health literacy, zero. And so you have to keep that in mind, and you have to start with the basics and talk to people as if they've never heard what HS is. You're going to come in as an expert because you have the disease or you're providing, but nobody else knows what that is, so just start very basic, and that's going to also help you when you talk to policymakers. They know nothing, y'all. Like, they know they're supposed to make all these decisions and all in energy and education and healthcare. Nobody is an expert in all those things, and so I think it's starting to talk about it in the community engagement, meeting them where they're at, and just starting at the very basic level.
I think too, because I was just talking about this, understanding what certain communities are sort of like, what are their conversations internally? So for an example, HS might mean something different to different communities based off of, like, for an example, let's talk about the Black diaspora. somebody from Haiti might be describing HS differently than someone who's a Black American. So we need to understand, what is that language, what are they using, and who do they go to, sort of like what Allison was saying, to receive care, because there are differences, and those differences matter. And it's important to meet people where they are, rather than trying to get them to come up to your level or whatever, you know what I mean? So that they can feel comfortable and they can feel like, it's accessible as well. And then two, I think sometimes we have to check our own assumptions about communities at the door when it comes to understanding like influencers, I like to say social influencers, because I feel like determinants means that there's no way of changing these things, which someone explained to me, and I was just like, yeah, that makes sense. You know what I mean? We can change these things. They don't have to be what they are. So checking like what you think about these specific communities. For an example, I think sometimes when I come into rooms and people ask my opinion, they assume that I come from a space of not having access or not having a privilege. And so I have experienced the spectrum, but it's saying, okay, let me create space for this person to tell their story and not superimpose my own beliefs on what their experience may be, if that makes sense. So I think that can also help as well.
Yeah, I think to build upon what you both were saying, I think it's a matter of shifting culture within our society, the way we approach chronic diseases in general, the way, our world is so used to everything being all or nothing. You can work or you can't work. You have a disease or you don't have a disease. But now it's how do we live in the space that we have? How do we function in that space, especially if we do have a chronic disease? There's one other. This is interesting. I just learned about this, and you both can probably add more than I know about it. But when you talk about some structural things that have been implemented from above, so everyone is, I'm sure, familiar with the opioid crisis. Well, now there's another opioid crisis. It's the opioid crisis where there's been so much regulation put into place by the government that now they're actually limiting the distribution of the opioids to different pharmacies based on what they prescribed the year before. So now there's another game that's happening because the pharmacies aren't getting enough of the pain medicine. So people are rushing really quickly to get their pain medicine as soon as possible, because if they're on chronic pain medicine and they need access, they may not have the ability to get it. So, yeah, I don't know, but it's very, very interesting, and it just continually amazes me how the intent of all the policy early on was really, really good. It's how can we control the opioid crisis, but look at all the things that's happened.
Yeah.
And that's what we really need to avoid and see the future and try to prevent those things from happening.
Well, and I think that speaks to kind of the need to engage and lean in and to say, wait a minute, these are going to be unintended consequences of what you're doing. Let's play out the policy that you think is going to be, altruistic and great and whatever, but let's really translate how that would play out for the end user, the patient who's going to be impacted at the end of the day.
If I can say, so that's why I love that we had the alternative medicine panel, because to kind of like piggyback off of what you were saying about opioids, I think if you think about these other things like cannabis and psychedelics and things of that nature, there's this stigma built around it, as if it's something that's dangerous, poisonous, all this other stuff. But there's so much amazing research in these areas about what psychedelics can do for pain, what cannabis can do for pain. And when we remove these barriers to these access, patients who, because these are indigenous medicine tools. These are tools that have been around before, America has even existed. You know what I mean? So when we stop making things that patients need in order to live inaccessible just because of other people's politics or opinions, then I think that people can choose rather than saying, do you want, opioids or Advil? You can say you have a whole spectrum of things to choose from, and here are some practitioners who can also help you to figure out, how do you use this in an effective way?
Yeah, and what's going to work best for you.
Exactly.
Yeah. Yep. When we're looking at like a health system, and how health systems can better wrap their arms around HS patients. We've talked a lot about that, how there's a lot of comorbidities, there's a lot of things that HS patients require to really build kind of their dream team per se. What are some of those aspects that you would say are key ingredients to building that dream team, and how health systems can better support patients?
I don't mind taking that because I also wear an executive hat at a healthcare system.
Yeah.
So I think the chronic disease navigator is something that could be really helpful within a healthcare system. When we think of congestive heart failure, when we think of chronic lung disease, there's pathways that exist in all the healthcare systems to get you access to care. Now, why? I know I keep going back to the why, but why are they putting so much energy into this? Well, the reality is they want to keep you out of the hospital. Okay? So what we have to figure out with the HS patients is, and show them, or any chronic disease patient, is what is the why, and why is there value to the healthcare system? Because the reality is that every program or every healthcare system is looking at the why beyond just the patient. But we need to show them that, and I think navigators can really help facilitate access to care in a timely fashion, communication, be a primary entry point for people into the healthcare system.
I'll say, and I'm going to jump in here, like there's just so much unknown, and I think we need a lot more information about HS moving forward and how to treat it, but also there needs to be, there's a lot of data projects that we could do, HS Coalition and other organizations about, are people going to the emergency room unnecessarily? What's it costing the healthcare system in a much broader space, and how can we start limiting trips to primary care physicians who don't know how to treat this, or how can we limit emergency room visits, or how can we limit, misuse of, therapeutics. I think there's a lot to be done in that space for us to understand, and for us to start talking about this is proper care, and this is why we're advocating for this. And bottom line, like you walk into a Republican office, they're going to want to know how it's going to save the system money. They're going to want to know how it's going to keep a patient off of disability, how it's going to keep patients in the workforce. And we need to start looking at those things and get serious about it, because guess what? Cancer's talking about it, cardiovascular's talking about it. We have to do it too.
Yeah, it's the numbers. They need the data, and they will not make decisions if they don't have the data available to them.
I think I want to plug that we have a session tomorrow about creating your dream medical team by Dr. Giaz and Yasmin Yoon. So I think that's something that you all can do to understand a little bit more of what you can do structurally, because they're going to help you to build that out. And then two, for example, Dr. Hamzavi was my physician for a whole decade. And so one of the things that he has talked to me about is not only going to him as a dermatologist to get care, but seeing plastic surgeons, then adding in a rheumatologist, adding in a urologist, adding in a gynecologist. And so when you see specialists, sometimes they have networks of people that they can connect you with. But if you don't have access to that, then that can be difficult to find, and it's not easy at all. But the HS Foundation has an amazing map on their website, and I point to people all the time that if you click on your state, you'll find a list of physicians that are near you, and if you can't, there's nobody in your area, then sometimes flying out, which I know can be difficult for patients, but that can also be helpful to see someone who can help you to build that team, so that you can get the care that you need.
Great. I want to kind of end with two very kind of practical questions for the audience here, for ourselves, of, how can we lean in here? What are some practical steps that we can take to advocate at our state level or local level to make changes to influence the health policy for HS patients? You go ahead, start.
Okay. Yeah. So, I think you all being here today helps empower you to tell your story. You are the most powerful person in a room. When you are with a policymaker, you are the expert. They are not the expert on your health and what you need and what your community needs. So I think, you leave here empowered, you go home, you start to look online. Who can you connect with to talk about it? Where to find, they're in an age of misinformation, like you were saying, where to find trusted information that can empower you to feel confident to talk to your policymakers, talk to your neighbors about it. I think, we look at this and we're like, oh, we have all this to solve, but it starts right there at home. It really does. And so I think just understanding how powerful you are, and how your story, look, those policies are black and white. You ever get a policy from your insurance and it's like this big and it's all black and white. Same thing about legislation, a bill, whether it starts in the House or Senate, it's black and white, but you humanize that and you make them think about it in a way that's not just numbers, even though numbers are super important. It's more about your story and how you can begin to have those conversations.
So when I started out in this work, I didn't know a lot, and I was confused majority of the time. It was almost like stuff was going in one ear and out the other. I was like, I don't know what y'all are talking about. But as I started just showing up in these spaces and started asking questions, being honest, doing research, just volunteering to be in these spaces, I started to learn. And I think I would give the same advice to people with HS, patients, to just start showing up and then to own your own story. I think owning your own story will help you to influence some of the people who are at the top making these, laws, these, creating these systems and things like that. So when you own your diagnosis, take a look at your own story, hone in on the parts that have the things that have created like difficulties and barriers for you, and use that as a way to kind of influence and whatnot. And it's a lot less scary than you think. I just went to Hill Day with CSD, which, before that, I was just kind of like, I have to talk to policymakers? Like, that's crazy. Like, there are all these high-level people. I'm like, what am I supposed to say? But there were so many different patient advocates that just, like, calm me down. They're just like, like you said, you know your story, you know what you're dealing with. So just speak from that space and be honest. You don't have to be an expert in HS to be able to tell and own your story.
And the Capitol Hill's just went to 25-year-olds anyway, right? That you're talking to.
Yeah, it's comical. When I went to do a public policy thing, and literally we were met by like college kids and high school students in hoodies. Anyways, so what I wanted to say is healthcare, these systems are complex. And that being said, it's a really great time for us to make change because we have so many great people who are working on things from so many different angles. And as much as we've talked about some of the barriers that exist and how frustrating the barriers are, we've had a lot of wins and there's a lot of successes. One, for example, many patient advocates in the HS Coalition are working with some of the state pharmacy boards to help increase access to the different drugs for Medicaid. You can speak to this much more articulately than I can, so feel free to jump in. We've been looking at the data on what access to healthcare looks like to pull out those numbers that we're talking about. HS Coalition actually had an abstract and a white paper that we put together, which looked at, I think it was 5 states, and what their overall approaches to the things that are important to HS patients are in terms of the access to care, the coverage, the access to the drugs, and so forth. So there's a lot of great work going on, and there are people here who really, really want to help and support you. The best piece of advice I can give you that I often give a lot of the other patients who I work with is you need to go, even when you go to see your healthcare provider, you need to be the expert in the room. Because many of them don't know, and it's not their fault they don't know. It's just that, again, there's so much to know. Training can be sometimes limited, and the more you can help guide them and ask the right questions, the better care that you're gonna get for yourself and the better partnership you're gonna have with them. And I'm gonna leave you with one interesting story that just came to me. So let me jump back and say a lot of healthcare companies, how they approach things and what what they're willing to cover or not willing to cover are based on clinical practice guidelines that also come from the different professional societies. So like surgeons have their practice guidelines for how they do things, and dermatologists have their practice guidelines for how they do things. And these things, which are really important, they actually keep physicians up to date on this. By every year they have to answer questions and read material and relearn stuff. So the American College of Surgeons, okay, so organization that represents all of the surgeons across the country, thousands and thousands, I pulled their resident education and their guidelines. It was completely false and incorrect for HS. So Dr. Dave Louie and I last year rewrote the entire resident education, which then will trickle into continuing medical education, which will trickle into this is how we practice medicine for HS, and then that goes into the policy. So hopefully you can see that we're tackling things from all different directions.
Yeah. I would echo also what Jasmine said. I've done some advocacy work as well, and you'd be incredibly surprised that policymakers are eager to hear from you and they want to hear your story. And if you reach out and you schedule that meeting, they will be there. It's very intimidating to like step your foot through that door, but once you're there, I found them to be very personable.
That's their job.
That's their job. You work at their constituent, so they want to hear from you. And if you're telling your story and telling about the barriers that you experience day in and day out, they are likely to hear you. They might not be able to make change, but you've at least had your story told and you've been heard. I think we're running short on time. Do we have any time for questions, or we do have time for questions? Just a couple. Okay, great. We'll open up the mic if folks have any questions. We have a couple minutes.
It was more of a statement. When I was like going to the doctors and stuff like that, honestly, what you said of like it going through one ear and out the other, I couldn't relate more because I've been thinking about that all day. I was like, these people are really sitting here talking to me. I have no idea like what they're saying. They're talking about we're gonna do this with that, with this, with that. I'm like, do what you gotta do. As long as the pain will go away, I don't care. Go crazy. But it's so nice to hear that, because I was just like, I thought I was the only one, because I don't have a clue, still don't. But it is important to get into those spaces and learn more about it. So thank you for this space.
Yeah.
Thank you. For those of us that are in the legal profession, what would you recommend for us to be able to help and to advocate as well?
You know how to write a bill? No. No, I mean, there's just plenty that you could do, you know. I mean, it could start with something just so easy about writing a resolution, contacting your legislator about a resolution for HS. I know, like, right now it's week. Why isn't it a month? Everybody else gets a month, you know. Let's play equal. Let's play fair here. So it could start with that. It could start with, you know, helping patients in your network with the appeals process. That is very difficult. A lot of people are denied medication and they don't know that there's an appeals process. And, you know, you get this letter and it's convoluted and it's confusing and people don't understand the language. As someone in the legal field, you could probably navigate it better than anybody. And so helping them navigate that appeals process, whether it's Medicaid, Medicare, commercial insurance, there's that ability there. And I think those things are super important for patients and like helps empower them, because once a patient gets to the place where they're controlled. So in the HS world, if there's no flare-ups, they start feeling a little bit more empowered and paying it forward, right? And they can start telling their story. But while they're navigating the new diagnosis, or they're navigating the pain, the suffering that comes with it, like they don't have time for that. Like, you know, we really need to get to the bottom of it. So I think those are really two good ways that you could engage locally.
Wonderful. Any other questions? Wait.
Hi, Hi, so just to touch a little bit more about the continuing medical education, I was actually interested in looking into it myself because I aspire to be a PA one day. And so through that, I couldn't find a lot of resources out there, unfortunately. And there is a PA back at home that does have HS, and she wanted to further extend research about that. So any idea if there's potential graduate schools that have specialized for HS so that they could be able to be in more of the dermatology space or anything like that?
So at which level or which profession are you talking about? From the PA profession, the NP, or the physician?
I would say at the PA level.
So the PA level, when you look at training right now, if someone goes to PA school, they actually get a lot of on-the-job, hands-on, procedural-based training, which is really good. I don't know of any subspecialty programs that are focused specifically on HS, but HS Foundation has really, really good resources that can turn anybody into an expert in HS.
Yeah.
So this is all vetted information. It's trustworthy information, because it's true. Right now, there's so much misinformation out everywhere, and it's hard to tell what's what. So definitely look at their website, and that would be a good guide for her to help become that expert, learn things, and then link up with other people who can help give her that support.
Yeah, and I'll give two plugs. One is for SHSA, that's in this fall in Austin. It's a medical conference that's coming up. I would search that, attend if you can. It's like, what is it, November 1st to the 3rd or something like that?
It is, and I'm just laughing because I'm the chair of that right now, and
you
I
didn't
totally
even say
forgot
it.
to say it. That's right. But we do have patients who join us, and it is fantastic. It is a research-focused. It is so it's focused. It's not as practical. It doesn't provide as much practical patient information, but more so looks at what is the new research, how do we integrate that into overall care. But we do have a bunch of folks who join us who are patients and our patient advocacy groups and advocates, and we really enjoy learning side by side with you.
Yeah.
So that's also available on the HS Foundation website.
Yeah, and then the other thing specific for PAs, there's a Society of Dermatology PAs. I would encourage your friend to look into that society, and there's probably folks out there that she could connect with or conferences that she could go to through that. Yeah. Well, thank you, everyone. Last question,
Sorry,
right over here. Yes.
This is also more of a comment, but I'm a pediatric dermatologist, but I'm very involved in the American Academy of Dermatology Association. And this year, if there is something, like if you're like, I want to dip my toe into the advocacy pool, it can be really helpful to go for a bill that already exists or that's already being talked about. And right now, this year, for the first time in a long time, all of medicine is pretty much in agreement that Medicare payment reform is something that needs to happen, because right now, hospitals, nursing homes, major healthcare organizations get a reimbursement raise every year tied to inflation. Physicians are not allowed to have that increase, and we have actually been seeing decreases in reimbursement over the last several years, to the point where if that continues for another year or two, a number of private practices will need to close or be bought up by hospitals, which is going to impact patient access to care. So if you want to, like, they don't want to hear from me about how I want to make more money. Like, they're like, whatever, you're a doctor, you make plenty of money. But if you as a patient can explain why it's important to you that you need your doctor's office to stay open so they can pay their staff so that you can go see your doctor, that's an easy way to jump in now and lend your voice to that issue.
Yeah.
Yep. If
And
there's no money, there's no mission. Go
That's
ahead.
right. And that's a huge barrier right now, and that is impacting what you see on a day-to-day basis in terms of not feeling that you're getting the care that you need from the physicians when you're sitting there in their offices.
Yep. Well, thank you. Thank you all for participating. Thank you to our panelists for the discussion. I really enjoyed it. We will wrap this session. Thank you, Jasmine.